Welcome to Critical Issues in Eyecare, an MD-OD conversation, hosted by Nate Bonilla-Warford, OD, and JC Noreika, MD, MBA. Critical Issues in Eyecare is brought to you by Marco Ophthalmic, a leader in vision diagnostic equipment. Now you know.
Hello, Nate.
Hi, Jay, and welcome all to the first episode of Critical Issues in Eyecare, an MD-OD conversation. In this series of podcasts, ophthalmologist JC Noreika and I will discuss some of the major issues eye care providers face today. Let's start by sharing a little bit about our backgrounds. Jay?
I'm a community-based ophthalmologist in Medina, Ohio. I've been practicing ophthalmology for better than 30 years now. And when I finished up my ophthalmic fellowship at the University of California, San Francisco, I knew that I would never want to run my own practice. That obviously changed. Just as background, I brought my first optometrist into the practice in 1986, a bit of a pioneer. In 1988, knowing that I knew nothing about running a practice, I went back and graduated from Case Western Reserve University with a master's in business administration. I was one of the first private practice clinicians in the country to get one. Now they're giving them out at graduation every year. I write, I speak, and today, like a lot of days, I saw a full schedule of patients. For all that, this is my first podcast. Nate, be gentle.
Well, Jay, I'm very happy to be doing this with you. I am a little bit more of a veteran at podcasting. I practice in Tampa, Florida. I have a primary care and vision therapy orthokeratology practice. I'm the primary doctor. I have an associate who works part-time. I do some writing and some speaking, and I do some consulting in social media, and so this is one of my favorite formats to both receive and present information. I'm excited to be working on this podcast with you. So the point of our podcast here is that this is a conversation between me, an optometrist, and you, an ophthalmologist, and we're going to be looking for the critical issues that affect people in eye care, the professionals that have to deal with the rapid pace and the changes that are coming. And we're going to be talking about all the different ways that we can deal with that and give our different perspective and see how we can provide answers and resources for folks. So today we're going to talk about refraction and its delegation.
Well, I think you hit on a lot of important points. One, there's a tremendous change within the system, and healthcare as we knew it, as I knew it, is changing tremendously. Refraction, interestingly enough, is going to be a very important piece of the provision of vision care going forward, as more and more young people can access the system with vision care plans and insurance and whatnot. When you think about it, it's the most tangible thing that we do that patients can relate to. It can be the best diagnostician in regard to the peripheral retina, but the patient doesn't know that. They have no way of knowing it. But they do know when they get a good prescription, when they get a good refraction, when they can see better through their corrective lenses.
Well, I think that that's true, and I think that that's one of the reasons why so many of us in eye care, particularly ODs, I think, feel very passionately about refraction, and they have an almost visceral reaction. Let me tell you a quick story. When I was doing my residency, I spent a few days shadowing an oculoplastic specialist, and he was a really nice guy, and I really enjoyed my time with him. And one day it got a little warm in the clinic, and he took off his white coat and he hung it on the phoropter, and he looked at me with kind of a deadpan expression. He just said, "That's what I use a phoropter for." And ever since then, I think about that. I mean, I know that he's oculoplastic, so he's maybe a little bit different, but some of us, we just have different perspectives on what refraction is. Some of us like it, some of us don't, and so when I was in optometry school, I mean, even though we learned the eye, inside and out, refraction was definitely one of the cornerstones of our curriculum, and all of the optics and the ray tracing and Sturm's conoid and all that other stuff that we had to learn, in order to be able to do it well. But now we're at a point where, now that we have all of that, information, and all that experience from training, the question is, how do we best use it?
Well, interestingly enough, as you mentioned that you're following an oculoplastic specialist, and I think the key word there is specialist, because if you're in community-based vision care, as I am, and primary care to a certain extent is such a big piece of our practice, refraction and frankly our optical dispensary is a big piece. It's a big service for patients, so we have to do it well. Who does it, I think, is the issue, and is there any fall off in the actual outcomes? I'm not talking about the precision necessarily. I'm talking about the perception that the patients have relative to the happiness with their correction. Is there any fall off in terms of who does it? And that's what I'm really interested in, because as I alluded to the fact that, I'm an ophthalmologist, I'm a surgeon first off, but I'm also an MBA, and I've always liked business. I know most doctors don't. I love it. And I'm always looking for more efficient ways to produce better value for both my practice and the patient. And refraction is one of those areas that I think we're doing that.
Well, and that's where I'm at right now, in my practice. Up until relatively recently, I had always done I had delegated to some of the entrance testing and some of the very basic things, but I had always done all of the refracting myself. But I've had a few experiences that made me question whether that was the best way to go. And one of them, and this has happened a couple times, that really challenged me a little bit. I would sit down and I would talk with the patient, and I would sort of look over some of the data, the preliminary data that the staff had gathered, and I intended to ask the question, so it seems like your glasses are working well for you, and then they had taken it as I had already done all of the testing that I was needed, and I was then educating them that their glasses were working well, and that we were already done with that part. And that was really kind of deflated my ego a little bit, because here I was thinking, here I am the optometrist, and I'm in control of this, and the patients really want to see me with my hands on the phoropter, the laying on of optometric hands. And whereas I don't think patients are nearly that concerned about it. I think they want to feel confident in the process, and I think they want to be able to see well, but I just don't think that they care that much who does it.
Well, I would have to agree with you, but I take it to a little different level too, and this is where I don't want to get lost in the weeds, but let's talk macroeconomics for a while. We know. What do we know? We know that there's going to be an influx of an awful lot of people in the next few years into the healthcare system. We also know that these people are going to have to be serviced in some way. Vision care is a huge piece of that. So you have more patients coming into the system, and the ophthalmologist, the optometrist, the technician are going to be key components to how this gets done. because you're going to have to spend time doing what you do best. And my opinion of optometry is that optometrists are being trained much better than a previous generation or two ago in terms of being able to be diagnosticians and even prescribing therapies. Uh, is that an enlightened viewpoint? No. Again, what I'm saying is that I have always been a big proponent of allowing people to do what they do best. That's why I brought optometrists into my practice. They did refractions better than I did. So now what I'm doing is I'm looking at technology to see how good this technology is relative to the optometric refraction. I'd like to tell you a little bit about this in a little bit.
Yeah, one of the other things that's really changed my perception of this is that I got the Refraction system from Marco, our fine sponsor of the podcast. And so now, I have a wavefront guided refraction and an automated system. And so I had the interest before in delegating, for time reasons, because there's other things that I either could be doing during that time. And now I also have a way to do it because I've talked to my staff and they understand the way the automatic phoropter works, and they're up for it, and they understand some of the pressures that we're under as well. And so for me the pieces are starting to come together. I currently don't delegate any part of that, but I could easily see myself delegating the distance refraction and then me coming in and doing the near point analysis and looking at working distances and making clinical judgments about prescribing, and I think that that's a model that would work really well. Can you, since I'm the young buck here, can you tell me some of the things that you've learned over the years, maybe some of the challenges to delegating, that particular test, and how that's evolved over the years?
Well, let me say first of all, it's not hard to convince ophthalmologists to delegate refraction. As far as optometrists are concerned, though, there's a control issue that, and they take the ones I've worked with have taken great pride in the final product and the outcome and whatnot. We still keep them involved, and I'd like to share with you, Nate, how we do it currently. Let me tell you a little shaggy dog story. About 4 years ago, a woman who had been with my practice, now 25 years, was the administrator, and this is a big practice. And she came one Friday evening and said, Dr. Noreika, I don't think I can do this anymore. I'm burned out. I've been there, done that. I want to do something else. And I said, what is it that you wanted to do, Tina? And Tina said that she had watched her grandmother through many caregivers and said, I want to take care of older people. I want to work in a nursing home or something like that. I said, well, my practice is rife with the elderly. You're great with them. Why don't we make you a technician? And one-on-one care. No more sitting in front of computers. I can't do that. It's possible. I don't have the background. I don't have the interest. I don't want to spend years studying it. I said, well, why don't you become my refractionist? And she looked at me and she said, what do you mean? I said, well, we have the Epic 5100, the wavefront. We got two TRS 5100s in the lanes, and let me just show you that you can do this. So I sent her down to Marco, to Jacksonville. She trained there on the course of a weekend with the expert people down there. They're amazingly good. And she came back, and that was, 4 years ago. Break-in period, maybe 4 weeks, building confidence in what she could do. She's my best refractionist right now. She has fewer remakes than my optometrist does. Now, that's not to say I've got a bad optometrist. We don't have many remakes. But the point is that here's someone who had absolutely no background, and because of the technology, she loves what she's doing. She is the antithesis of the ophthalmologist. She loves helping out these elderly patients see better, and it's all because of the technology. That's a great story, but in a few minutes I'll tell you an even better one with a little bit of a scientific twist to it.
Yeah, it is a great story, and I can tell you that my staff aren't anywhere near to that point yet, but they're excited about the possibility. I have a wonderful staff, and the patients absolutely love them, and one of the reasons why they're so great is because they're always chomping at the bit to do more, and they're asking me if they can do more things or take on more challenges. And I know that in some states it's not legal for optometrists to delegate that particular test, refraction, which kind of boggles my mind a little bit. I don't really feel like our profession should be that micromanaged that they're told what they can and cannot delegate. But so for some optometrists that's it's a legal issue. But for me, I definitely see this in my future, and I think due to just overall changes in the landscape that you were talking about, it's something that more people are going to be looking at.
Well, the story that continues, because as I said, I had such great success watching Tina develop, and she took such great pride in the work. And having someone who enjoys her work so much is also a great thing. But the more recent thing, and this initiative came about because of Tina's success, is that I wanted to anticipate what was coming with the changes in healthcare. So I decided to add more refractionists. Well, try to go out and hire a refractionist, okay? Anybody who's decent. That ain't going to happen very easily. So I took 3 of my more, what would you say, energetic people who like a challenge, who want to advance, who want to go to the next level. 3 of them. And I sent them to Jacksonville for the weekend. They went through the course, and they were going to learn how to refract on the Epic 5100. Now, these are newbies. These had, one just came out of a optician's program. Another was a right-hand person of mine who more or less saw to the flow of the office. And the third one was a front desk person who decided that she liked the technical side better, but didn't know exactly where to get started. None had any refracting experience. So now this is recent. This is contemporary. So what I did is we set up a system where they are now refracting. And they are refracting our optometrists' patients on the Marco system. How this is a little bit different is that the optometrist then has the final say of accepting or rejecting the refraction. Feel free to refine if you want. You want to check near points? No problem. You do it. But we're tracking these. And the preliminary data, we're not finished yet. We wanted to get exactly 100 patients, 33 per newbie, and then look at them critically. And we're tracking these. The preliminary data shows this is very, very promising in terms of being freeing up the optometrist to do more of what she is trained to do in the clinical sense and get away a little bit from the refraction. She still is involved, and she can do as many refractions as she wants, but she can also pass on some that, if they go to the wavefront portion of the Marco equipment, they're pretty much dead center perfect. So if she wants to refine them, fine, but we're tracking this. I plan to write this up and hope to have it published so that others can see this data. But I will say the preliminary data is impressive. It gives me another opportunity, though. The newbies are not going to have any type of experience comparable to our optometrist or even our ophthalmologist. And when we find a problem, when we identify that, they're changing the axis too much or the cylinder too much or something like that, it gives us a chance to educate, and they get better. The newbies get better. And so I'm excited about this because, frankly, my optometrist is going to have to see more patients. And they're going to be young, and they're going to be generally healthy. They're going to be on vision care plans, and with the reimbursement of vision care plans, I can't afford to have her bogged down or him bogged down in a difficult refraction. So I think this is very exciting because we're going to find out for sure just how applicable this technology is to the modern day practice.
Well, I really look forward to to seeing that when you get that written up and published, and I'm sure lots of people do. I know that there are some other studies either out there or currently being in the process of being published that's sort of looking at some of those same things, the reliability of the delegation of refraction and what that results in from a patient perspective. And so I like that there's some data out there, and that it's not all about the time crunch. Of course, that's a component, but we want to make sure that we're always providing the very best care that we can, and so preserving that and even enhancing the quality of care is just really important. So that sounds really exciting, and hopefully that as we continue with this podcast, or over time, I can kind of slowly document my progress in getting my staff on board. So maybe I can kind of share my journey as we go along in that route. Did you have any other things, little last minute thoughts that you wanted to get in before we wrap up our inaugural episode?
Two final points. One is that this technology, this Marco refracting system, especially the wavefront aspect, is made for the younger, healthy eye. It's remarkably accurate. The second piece I'd like to say is don't discount the wow factor. Patients are becoming spoiled by all our technological advances and gravitate to those practices that quote-unquote keep up. And if you want a little bit of sizzle with the refraction, the EPIC or the TRSs certainly provide that. So whereby it may be quote-unquote a technician who's doing the refraction, the technology offsets any adverse impression from that. This practice is advanced. This practice is investing in all the good stuff. So keep that in mind.
The next opportunity that you might get to visit Marco and tell them that you appreciate the podcast is at Vision Expo West in Las Vegas. Their booth is MS 8031, and they'd be happy to talk to you about any of the technology that they've got in the pipeline, as well as out there now with doctors that are using it. This is our first effort at this, and so if any of our listeners have ideas of topics you want us to cover or guests that we'd like to have on, certainly let us know. You can contact us on either marco.com or find Marco Ophthalmic on Facebook or Twitter. Thanks, Jay. Talk to you next month.
Sounds good, Nate. Thank you.
This broadcast is sponsored by Marco, redefining the art of refraction through superior understanding of every patient's total visual system. The Marco extraction process combines wavefront technology with digital refraction